Let's dive right into this explainer. Today, we're unpacking a truly high-stakes medical emergency, acute kidney injury, or AKI. Now, we all know the basics of acute renal failure, but today we are looking at the exact biological mechanics of a system crash that doesn't just quietly develop. It strikes hard and it strikes fast. We're going to map out how the body sounds the alarm and the intense medical rescue mission required before permanent damage sets in.
We have a lot of crucial ground to cover today. Here's our roadmap. First, a sudden medical emergency. Second, inside the kidney's filters. Third, 3 types of injury. Fourth, warning signs and diagnosis. Fifth, emergency treatment and dialysis. And finally, the road to recovery.
All right, starting with Section 1, a sudden medical emergency where the kidney filters suddenly go offline.
So here's the thing about AKI. It is a brutal race against time. We're talking about a precipitous, sudden decline in kidney function that happens over just a matter of hours or days. You know the kidneys are our master regulators, right? But when this condition strikes, they instantly lose their ability to filter waste, manage fluids, and hold that delicate acid-base balance. It's an immediate emergency. And if it's left unchecked, it spirals rapidly into multi-organ failure. Now, while this can technically happen to anyone, it really preys on vulnerability. It heavily targets hospitalized older adults and folks who are already battling major systemic stressors. Think diabetes, hypertension, heart disease, or liver failure. Honestly, walk through any ICU and you'll see it everywhere, especially in patients fighting sepsis or recovering from major surgical trauma. Basically, when the body goes to war, the kidneys are often the very first to wave the white flag. Moving right along to Section 2, inside the kidney's filters. Let's look at this microscopic machinery. 1 million. Seriously? Take a second to wrap your head around that number. That is roughly the amount of microscopic filters, called nephrons, packed into just one of your kidneys. Right at this very moment, they are relentlessly pushing blood through the glomerulus and into Bowman's capsule. They're doing all the heavy lifting, balancing electrolytes and driving the renin, angiotensin, aldosterone system. It is an absolute marvel of biological engineering. But when that engineering fails, man, the breakdown cascade is basically like a row of dominoes falling. First, blood flow suddenly drops, or a direct injury hits the tissue. Second, those millions of nephrons take physical damage. Third, your glomerular filtration rate, or GFR, absolutely plummets, which causes waste like urea and creatinine to spike in the bloodstream. And finally, as filtration halts entirely, the whole system just gets overloaded with fluid and incredibly dangerous electrolyte imbalances take hold.
Which brings us to Section 3, 3 types of injury categorizing the AKI culprits.
Medical pros actually group these culprits into 3 specific attack vectors. It really helps to think of the kidney as a giant water filtration plant. Pre-renal is basically a loss of power or water supply to the plant, so reduced blood flow before it even reaches the kidneys, usually driven by dehydration, hemorrhage, or shock. Intrinsic means the internal machinery of the plant is broken. This is direct tissue damage from things like acute tubular necrosis or nephrotoxic meds. Finally, post-renal means the pipes downstream are blocked. We're talking about an obstruction after the kidneys, like severe kidney stones, an enlarged prostate, or even a tumor. Here we are at Section 4, warning signs and diagnosis. Let's identify the alarms. When things go wrong, these symptoms are essentially the physical manifestations of the body poisoning itself. The most immediate red flag? Oliguria or anuria. That simply means urine output has dropped significantly or stopped entirely. Because the fluid can't escape, patients develop severe swelling in their feet, ankles, and face. And it gets worse. This fluid can actually back up into the lungs, causing acute shortness of breath, a condition we call pulmonary edema. Now, fatigue and confusion definitely set in from all that toxin buildup, but the most dangerous alarm of all is invisible. It's an irregular heartbeat triggered by a lethal spike of potassium in the blood, known as hyperkalemia. To track this escalating crisis, clinical guidelines like KDIGO break it down into 3 strict stages. Stage 1 starts off with a mild bump in serum creatinine, paired with reduced urine output. By stage 2, the kidney injury is moderate and compounding. And if a patient progresses to stage 3, well, we're looking at severe kidney failure, where they might urgently require mechanical intervention, like dialysis, just to survive. Pinning this down and confirming the diagnosis requires some seriously rapid detective work. Physicians rely on immediate blood tests tracking creatinine, BUN, and electrolytes, alongside a urinalysis for clues of intrinsic damage. They'll also deploy ultrasounds to rule out any physical post-renal blockages. And crucially, they'll often calculate the fractional excretion of sodium, or FeNA. It's a brilliant tool that helps them distinguish whether the issue is a pre-renal blood flow problem or an intrinsic tissue failure. Like we said, it's a highly coordinated race against the clock. Okay, Section 5, Emergency Treatment and Dialysis, the medical rescue. Once the clock is ticking, the treatment approach basically splits down two paths. Standard medical treatment is all about correcting the root cause, right? Administering IV fluids for pre-renal dehydration, deploying antibiotics for sepsis, stabilizing blood pressure, and immediately halting any nephrotoxic drugs. However, if the kidneys completely shut down and life-threatening complications hit, like that severe hyperkalemia or pulmonary edema we talked about, doctors have to pivot to emergency hemodialysis. A machine actually has to artificially take over the kidney's job to clear the blood. It is literally buying the patient time.
But here's the thing. Surviving that acute emergency? That's really only the first step in this journey. It begs the question, what exactly happens after the immediate crisis is averted and the patient finally stabilizes?
And that leads us to Section 6, the road to recovery and protecting that function. Because acute kidney injury takes such a massive systemic toll on the body, recovery demands a full-on, multidisciplinary approach. Physiotherapy is absolutely critical. Patients need early mobilization, incentive spirometry, and resistance exercises just to combat ICU-acquired weakness. Nutrition is equally vital. A renal dietitian has to strictly manage sodium and potassium while perfectly individualizing protein intake. And ultimately, rigorous follow-up is essential. Because while many people do recover, some patients can quietly slip into chronic kidney disease if they aren't carefully monitored.
I want to leave you with a huge takeaway pulled straight from the clinical guidelines. It says, acute kidney injury is a serious but often reversible medical emergency when recognized early. In nephrology, time is quite literally tissue. Understanding these mechanisms doesn't just treat an emergency, it fundamentally changes the trajectory of a patient's life. And I think that leaves us with a really provocative question. In the age of all this advanced medical tech, are we paying close enough attention to the subtle, early alarms our own biology is sounding before the clock runs out? Thank you so much for joining me on this explainer, and keep asking those big questions.